So the first presentation will be by Dr. Susanna Naggie. She's the director of Duke Clinical Translational Institute, Vice Dean of Clinical and Translational Research, and Professor of Medicine at Duke University School of Medicine. Susanna, please proceed.
Great. Thank you so much. And thanks to the organizers for giving me the opportunity to be here. I apologize that I was late in joining due to our annual CFAR meeting, but I've seen some great conversation already. Hopefully you can see the appropriate display of my screen. So I'm going to go ahead and kick this off. I know I have 10 minutes just to briefly intro some of the concepts regarding directly acting antivirals for the treatment of acute hepatitis C, given the discussion that we've heard here in terms of what is that risk-benefit balance when we think about asking volunteers to participate in the type of research that you all have been speaking about this morning. So I'm going to give a little bit of background, which is just for the entire audience, and thinking about when someone is exposed to the hepatitis C virus, and the way clinically that we diagnose someone or classify that infection in terms of the stage of the infection. And what we know for the majority of people who are exposed to hepatitis C, because we do not have a preventative vaccine, the majority go on to develop a chronic infection. We define acute infection as someone who is identified as being relatively early in their infection course within 6 months, and then early infection is 12 months. And I think this used to be really relevant when we thought about therapies and treatment, and as we'll get to, I think it has become in many ways much less relevant from a treatment standpoint, because guidelines and clinical care have really moved along pretty significantly in the way that we manage patients with acute or early hepatitis C infection. I think everyone knows that hepatitis C is referred to as the silent epidemic. There's a reason for that, which is that the majority of people who develop acute, early, and go on to chronic infection never have symptoms that allow them to present to clinical care. That means the majority of them may have a mild viral syndrome that they think is any other virus, and that resolves, and that they go on to chronicity. They are not aware unless they see a provider or part of a screening program. So very few of these patients develop any sort of outward signs or symptoms of their acute infection, whether that be jaundice or a true fulminant hepatitis. And I think that's one of the things to really think about here is we think about other viral hepatitis like hepatitis A or hepatitis B that really do have significant levels of patients presenting with severe liver injury. That is uncommon, extremely uncommon, in fact, for fulminant liver injury in hepatitis C. Really differentiates hepatitis C from a clinical perspective from these other viral hepatitis. You can see that because of direct-acting antiviral therapies, the guidelines, as I mentioned, have significantly changed. There was a time where there were recommendations that you actually wait to see if someone naturally clears this infection, which, as I mentioned, is an uncommon occurrence. And so now the recommendations from the primary guideline groups, whether in the United States, in North America, or outside of the US, including EASL guidelines and the POSL guidelines, et cetera, is to treat people as soon as we identify them. Now, there is some difference, and we'll get into this a bit, in terms of what the recommendations are for therapy. So the AASLD-IDSA guidelines recommend treating someone right away, but treating them with the same length of therapy, the same therapy with direct-acting antivirals as you would someone who had chronic infection. So no differentiation of a treatment difference, whether you have acute, early, or chronic infection. The European guidelines do approach this a bit differently, which is a recommendation to use 8 weeks of one of two pan-genotypic regimens, sofosbuvir abatasphere or the glecaprevir preventosvir regimen, which I will refer to as GP moving forward because it's a whole lot easier to say. And we'll get into why that is. For soft-valve, this is actually a shortened course of therapy. For GP, this is the approved course of therapy for chronic infection, people who have naive or have never been treated or who have been treated with prior older regimens. So just want to summarize quickly, and really the landscape for this is to emphasize that it is really unbelievable where we are today with direct-acting antivirals. There really is largely only one population of patients that we take care of who do not have an approved access to DEA therapies, and those are pregnant people. But if you really think about it, beyond pregnant people, we have every patient who walks into my clinic would be able to and access DA therapy. I'm not saying pregnant people can't, but that is not something that's approved currently or recommended per our guidelines. But what we do have is approval for patient populations, including children, and I really want to emphasize, and people who have gone through transplants of their organs, whether that be a heart, a liver, a kidney, and people who have decompensated liver disease. These are people who have very sick livers, and we have found that these regimens are very safe in people whose livers are not actively functioning at a level that would be considered normal or healthy for them. And we also now have what we call salvage regimens. And these are regimens where if someone has failed our first-line therapies, we can rescue them and treat them with highly active salvage regimens to ensure, frankly, that no one goes uncured. So I'm just going to summarize the data that we have here for acute hepatitis. And remember, we really do have very few large studies that are looking at people who have acute or early hepatitis C. And that is largely because if you look at the approvals for these drugs, these approvals have come in under chronic infection, and there frankly isn't a lot of reason for a company to pursue a shorter course of therapy, which is largely what we would look at in a clinical trial for an acute infection. So just to orient you to this slide, I'm largely looking at pan-genotypic regimens, so either the soft valve regimen or the GP regimen. So in blue are the soft valve regimens, and they have been studied. This regimen has been studied at both 8 weeks, which is a shortened course, as I mentioned, and recommended by the European guidelines, or 12 weeks, which is where it's approved in people who have chronic infection. And the dark and the light bars in blue are basically differentiating a clinical trial, what we call intent to treat population, which is would correlate less well to what I would consider a real world study versus the population that is the per protocol population, which is PP, which is basically a group who usually has at least reported that they've taken at least one dose of the trial medication, or potentially had reported significant adherence. And so what you can see here for the GP regimens is that we achieve 100% cure in people who say, I took the pill. And remember, these are people who actually who have acute infection and may actually be different than a population who would volunteer for a study because they are people who have recently been exposed to hepatitis C. And there may be social drivers of health that would be challenging for these patients to actually access care, et cetera. When we look at the GP regimen, you can see that these are in the orange and yellow bars. And again, orange is ITT and the GP regimen in yellow is the per protocol. This regimen, because it's approved at 8 weeks, has only really been studied at 4 and 6 weeks, because the idea behind acute infection is to see if we can use shortened courses of therapy for these patient populations. And you can see that even with a shortened course of therapy to 6 weeks, we can see cure rates of almost 96%. I do show you in the 8-week arm, which is where this drug is approved for 8 weeks, you get to a 98% cure rate. And these are people with chronic hepatitis C infection and cirrhosis and severe liver disease. This is very different than a population of volunteers who do not have underlying severe liver disease. So again, the point of this is we can cure near 100% of people, whether they have acute, chronic infection, cirrhosis, or other underlying comorbidities. So what about the safety of these regimens? I've already mentioned that these regimens are approved, and specifically the ladipasvir, sofosbuvir, and sofosbuvir velpatasvir regimens in people with decompensated liver disease. So they really are safe in people who have severe liver dysfunction. And this is true in someone who has acute hepatitis C, who has that rare occurrence of an acute liver injury. We can treat these patients, and we can treat them safely, and we can get them to a cure. And I think that's actually really important when you think about that risk benefit that we've been alluding to. So what if someone does fail that first line of therapy? What I'm going to tell you is that we can cure them. In fact, when I meet patients in my clinic, patients with severe liver disease, patients who have been previously treated, I reassure them that we will cure them. And what I tell them is, we will likely cure you on the first time. And if we don't cure you the first time, we will definitely cure you the second time. But we're not going to worry about that second time, because likely we won't need to have that conversation. Now, you can see that these are very small numbers that are summaries from the clinical trials that you saw on that previous slide of acute infection studies. And you can see there are very few numbers here because so few people fail to begin with. But for those people who do fail, you can see here that the cure rate is 100% on the second time around. And I'm going to summarize this here in a what I view as a good example of a population that has seen significant change in clinical care because of our level clinically of confidence in the efficacy and safety of these DAA therapies. So many of you may be aware that we now provide organ transplant to people without hepatitis C from a donor who has hepatitis C. So we are transplanting organs with hepatitis C infection in them, which will ultimately transmit that infection to the recipient at 100% rate, essentially. And we do that because we have such high confidence in our ability to cure them after the transplant. Now, you could argue the risk benefit is very different here, and I would agree with that. But remember, we're also treating these patients who are on the other end of that transplant significantly immunocompromised. Frequently, we'll also have other medical comorbidities, and we'll have significant drug-drug interactions that we manage. And yet, as you can see here, the cure rate on the first round of treatment post-transplant is somewhere in the 96 to 100% range. And beyond that, if we retreat someone, it's 100%. And I actually give you an example here of our Duke experience, where out of 106 kidney transplants, 4 were not cured on the first round. These are very complex patients, and we cured those 4 with retreatment. And you could argue, why is that even publishable? But that just shows you how rare this experience is of needing to salvage someone in this setting. So to summarize, I think the considerations for this human infection model really is that we have treatment options. These are very different patient populations than what we're used to treating in clinical care, because they are volunteers and will not have some of the complications that we deal with in clinical practice. And I think these are some of the things that I wanted to put up just as maybe points of discussion. But ultimately, I do believe that these are patients, if they are transmitted the infection through studies, that we could ultimately rescue. And I will close there.
Oh, thank you, Susanna. It was great summary of our experience in treating acute C with DAAs. So let's move on to our next presentation by David Thomas. Introduce him already, so he certainly needs no introduction. Please, David.
Thanks, Jake. I'm delighted to speak to this topic of the long-term consequences of a resolved infection. And I've actually sort of rephrased it, because I'm asking the question of what's the risk of 24 or fewer weeks of infection. That's really what we're talking about here, is what's the risk to persons who are volunteering for a CHIM. So for me, those risks boil down to liver complications and non-hepatic complications, and I'll talk about them in that order. So the hepatic complications of hepatitis C are, of course, cirrhosis, end-stage liver disease, and hepatocellular carcinoma. The non-hepatic complications, I'll group in the lymphoproliferative lymphoma kind of category, the vasculitis category, and then the metabolic vascular heart and diabetes kind of groupings. And for each of these, I'll be asking, is there any evidence that these kinds of complications occur more often in persons with spontaneous clearance, being what I consider to be perhaps the best example, the best model to answer the question of what the risk would be for someone in whom we allowed infection to go on for up to 24 weeks. So do they occur more often in persons with spontaneous clearance compared to persons who have persistent infection? And then sort of insinuating some information from those that have had the infection for a few decades and then received DAAs. So that those will be our sort of paradigms, if you will. Okay, so I'm going to disclaim right from the beginning that there are, of course, some limitations. These aren't randomized controlled trials. I'm trying to make inferences from secondary sources of information. There haven't been randomized trials with decades of follow-up to answer these questions with the right amount of persons. So there's also the issue of confounding here, right? The people that get these they're participating in challenge studies may differ in many regards from persons who acquire infection naturally, but in their age and their comorbid conditions, and the competing mortalities. There's also things that are different about people that spontaneously clear compared to those that have decades of persistent infection. And it's possible that those could alter some of these inferences. And then we're talking about things that take decades to occur and occur from other things other than hepatitis C, which that makes this all very tough. Not only do they occur from conditions other than hepatitis C, but they're conditions that we can't measure very well. Smoking, alcohol use are sort of high on the list. So we don't really know how much anyone's ever ingested alcohol. So it's difficult to control and to carefully answer these questions. So with those disclosures, I'm going to pretty much conclude that I could find no evidence of long-term complications. And I'll take you through some of the data that led to those conclusions. First, for the liver studies, and I'll start with our own work from Baltimore, where we initially characterized hepatitis C infections in persons that had antibodies, and we didn't know at the time whether they had spontaneous clearance or not. And we noticed that the ones that had that there was a group that we later found out had no RNA, who had normal ALTs, who 20 of whom happened to have liver biopsies done, and in retrospect had no RNA and had no fibrosis, and then literally no elevated liver enzymes in a group of 177 without viremia, but in whom spontaneous clearance had occurred. We have also done extensive elastography, just a snapshot of time of 930 with undetectable RNA, and compared to 6,578 with viremia, and the elastography results are considerably lower. Now they're not all what we would consider normal, because of course we have some with BMI, high BMI, and some with alcohol use, but they're clearly lower. And then to this other paradigm of the DAA response, once individuals receive DAAs, we see marked reductions in cirrhosis, marked reductions in those fiber scans over time, with literally 72% reduction in the prevalence of cirrhosis at the cohort level after adjusting for HIV, BMI, and age. Okay, mine is not moving anymore. Let's see if I can move it this way. Okay. Another cohort where we have spontaneous clearance results is that I'll show multiple times is the Taiwan Reveal cohort, 23,820 individuals, 30 to 65 years of age, enrolled from 1991 to 1992. So long-term cohort, looking at mortality, cause-specific mortality, comparing those with anti-hepatitis C, with antibodies to hepatitis C, according to whether they're RNA positive or not. And you'll see a family of curves. I'll show you the first one here in cumulative mortality related to chronic liver disease and cirrhosis on the y-axis, time on the x. The little dotted lines are the RNA negatives, the solid of the RNA positives. No evidence of long-term cirrhosis or end-stage liver disease in those who had spontaneous clearance. Another valid control group are the German anti-D, and it's similar findings from the Irish anti-D. These are women who were accidentally inoculated with immune globulin contaminated with hepatitis C. In this study, 718 women who were hep C antibody positive, and 189 of them had spontaneous clearance. 2 of those had cirrhosis, but one was clearly from alcohol, and the other one had alcohol in the background as well. So these women, the authors concluded, spontaneously recovered and had no permanently cleared, were protected from liver fibrosis progression. So another form of negative information. So I show you those examples to reach the conclusion that I find no valid evidence that 24 or fewer weeks of viremia would lead to serious end-stage liver disease or cirrhosis or liver fibrosis accumulation. The other liver outcome, of course, is hepatocellular carcinoma, and there's some really intriguing in vitro and actually ex vivo data on liver epigenetic changes in liver that might have suggested that that hep C replication alone might lead to hepatocellular carcinoma. But kudos to Christine and Jordan and David and others who put this paper, this massive paper, into the CID supplement. I won't go over the details of it, but I'll just say that this is your one-stop shopping to answer this question. These are some of the papers that they highlight for spontaneous clearance. Notice in the third column, the incidence per 100-person years from some of these same cohorts I've already presented to you, the German anti-D women, the Irish anti-D women, that reveal one I've already shown, and then a large VA cohort and a cohort from British Columbia. And in these cohorts, very low incidence of hepatocellular carcinoma to 0 in persons with had spontaneous clearance. So I found no conclusive evidence, despite the biologic plausibility presented by those intriguing histologic findings, that there would be any risk that we seriously need to consider. And here are those reveal data. I've summarized them in that table, but here are their Kaplan-Meier figures, cumulative mortality on the y-axis, reveal cohort, comparing those with spontaneous clearance in the little solid line, the solid gray line, persistent infection in the black line, and then in the dotted line, individuals that were antibody negative. And you can see just a slight increase in the antibody positives, but even these authors concluded that there was that could have been confounded and was unlikely to have been caused by the hepatitis C infection. Notice that in the first 10 years, there were no differences. So that's cirrhosis, that's hepatocellular carcinoma. This other category of non-extrahepatic, I'm going to highlight this paper for your one-stop shopping. Patrice C has done most of the work on this topic, and is a person whose opinion I respect. I asked him, because it's a little bit more complicated to get your head around these outcomes, if by email a couple of days ago, and he says if patients spontaneously clear their virus, they have no risk to develop such extrahepatic complications. That's his view. And some of the data that contribute to that would, for example, one of this reveal cohort that I've been showing from Taiwan, again, those with hep C RNA in the black line have a higher mortality related to extrahepatic disease than those who are hep C negative and hep C antibody positive, RNA negative, and those lines overlap. The Irish immune globulin cohort, again, women infected at relatively young ages who had hepatitis C according to whether they were PCR positive or negative. And you can see that none of these persons infected at a young age developed vasculitis, whereas there were a considerable number in those that were hep C RNA positive. The VA cohort has also done some massive studies using their ICD-9 coding, and again, substantially fewer instances of extrahepatic cryoglobulinemia, porphyria, lichen planus in those according to the RNA status. Here, looking at SVR compared to no SVR. So this is among persons with decades on average of infection after SVR compared to before SVR. So in conclusion, my summary, brief as it is that having reviewed a number of these papers, I really can't find any evidence of convincing long-term hepatic or extrahepatic consequences from that can be attributed to less than 24 weeks of HCV infection, and that includes the well-known complications of Hep C, hepatic and extrahepatic, and the forms of evidence being the spontaneous versus persistence, added confidence by examining after DAA cure, and the caveat that we really, of course, couldn't exclude very low risks of long-term complications, just as with other CHIM paradigms. So I'm going to end there, Jake, and hand it back to you.
Great. Thank you, David. It's a really comprehensive review of the long-term risks of cell-limited acute HCV infection. So I think we're going to move on to the second panel, which will be run by Jurgen Feld. Jurgen is a professor of medicine, interim director of Toronto Center for Liver Disease, and Phelan Chair in Translational Liver Research, Disease Research at the University of Toronto. So Jurgen, please proceed with the panel discussion, which I very much will look forward to, because we have a lot of really world-class experts in hepatitis C to chime in on these topics.
Great, thanks, Jake, and thanks to Susanna and Dave for great presentations to introduce this panel, and great to have both of you on the panel. And in addition, we have some very illustrious colleagues who need little introduction, but I'll just mention their names and where they're signing in from. We have Graham Foster from Queen Mary University of London. We have Christine Su, who put together that great systematic review on the risk of liver cancer, who works in the liver diseases branch at the NIH. We have Jurgen Rockstroh from the University Hospital Bonn, and Norah Terrault from the Keck School of Medicine at the University of Southern California. So great to have all of you. And maybe we'll just go back to the panel view. And I have a few questions that come out of the discussion. And I also would encourage any people who are viewing to put your questions in the Q&A, and be happy to share them with the panelists. And I like Graham's eagerness because he's got his hand up before I even ask a question. So I'm going to say, Graham, please give me your comment before I ask a question.
Thanks very much, Jay. I'm going to go to David, if I may, about the thorny issue of a post-viral fatigue syndrome. I think all of us who have published on hepatitis C associated symptoms are aware people with infection do have a chronic fatigue syndrome that mostly abates when you clear the virus. But there are a cohort of people who have a persistent fatigue syndrome that may or may not be related to infection. My anecdotal experience is there are a group of people who are antibody positive, RNA negative, who do complain of chronic fatigue and the brain fog. Many of them associate it with infection. I'm not aware of any high quality research investigating it. It is mainly anecdotal, but there are certainly cohorts of patients whose fatigue coincides with infection. It seems to be particularly common in some countries. I have some exposure to Irish ladies infected in the anti-D cohort, many of whom who've cleared and do seem to have a fairly persistent post-viral fatigue. So I'm keen to hear other colleagues' views on whether this is a real issue and how we should deal with it in a challenge trial.
Dave, do you want to start since the...
Yeah, I can. Graham, it's a great point. My final bullet where I said that I didn't feel like there were any risks different than other CHIMs was actually written thinking of that point of yours. In other words, any infectious disease can, of course, cause post-infectious fatigue, and so yeah, I mean, I do think it's possible that might occur. I had thought that the Irish women did do some, or the Irish investigators had done some formal testing, neuropsychiatric type testing, and concluded that the lack of viremia was associated with much lower depression and CNS. But you sounds like you have firsthand experience seeing them, so I certainly defer to you on that point.
I think on a population level, there does seem to be a dramatic improvement, but there's no question there's a small cohort of people who have persistent symptoms. So I think we need to factor that into the patient information And I'm aware there's been quite a correspondence in the chat about how detailed we need to be, but my argument would be this is something we need to highlight.
I think it's a great point, Graham, to bring up. And I think one of the things that I know Christine and I spend a lot of time thinking about with others is this question of how do you actually answer these questions? It's very hard to sort of prove a negative, and particularly with things which are harder to measure, like fatigue, but even with very objective metrics of liver cancer, one of the things, and maybe Christine can comment on it, is this issue of how when people are tested, is that a confounding issue in and of itself? So are we really getting a true population of the population of people who've been exposed and cleared versus a population of people who have a reason for testing? Christine?
Yeah, I think the challenge is that, we just have very limited data on I was looking for spontaneously clear cohorts, and we have very limited cohorts that kind of have a natural history, long-term health complications. Even with the Taiwan Reveal cohort, hepatitis B, core positivity was not accounted for, which can be a confounder in HCC outcomes. With the U.S. Veterans Affairs cohort, patients were tested for, at-risk testing. They were tested for liver risk factors, which led to the Hep C diagnosis. So a lot of patients had underlying, comorbid conditions that may have not been captured, like underdiagnosed mast cell or underdiagnosed alcohol, associated, liver disease. So I think it's hard because I think I think with the fatigue, a lot of the patients that have the fatigue have the chronic infections. And I think trying to extrapolate that to kind of apply to people who are treated in less than, 24 weeks has been difficult. And, with the spontaneously clear cohort, while majority of the patients clear in the first 6 months, but there have been some patients that cleared, beyond 6 months. So it's really hard to understand if this is truly reflective of the healthy population we would recruit for the CHIM. So.
Great. I'm going to go back to the discussion about treatment in acute hepatitis C. Thanks, Susanna, for that great overview about it. I can tell you when we talk about CHIM, the first question that anybody asks is, what about the 5% who don't respond? So you sort of showed us that seems unlikely in the acute setting. But I guess I just want to push you a little bit on that and ask you, how do we explain this and how confident can we be about curing everybody?
Yeah, I think the data does largely speak for itself, and you don't want to. I think you do have to make sure that folks understand that promising 100%, I think, can be difficult. But frankly, I do feel quite confident in saying that with the current DAs and options for potential rescue on a second round, that we can cure 100% of people. I think that the data that we have across the spectrum of people with hepatitis C says that's true. And I also think that the access to drugs is going to be different for this population than in people who have, as I mentioned earlier, drug-drug interactions and other complicating, potentially comorbidities, et cetera, that can sometimes limit how we treat folks, right? I think that was true in the transplant population. But I'm pretty confident based on the data and clinical experience that we can rescue any percent that fails the first time. I think 5% is high in this population. Honestly, I think we're really talking about the potential for 1 to 2% max of potentially needing retreatment, if any, honestly.
Jurgen?
Yeah, let me just comment on that question you raised, which I think Susanna already answered very nicely. I think we have to take into account that a lot of the studies in people with recently acquired hepatitis C were done in certain populations, including people with HIV co-infection and then drug users. And obviously they come with a lot of comorbidities. Remember, the clearance rate in HIV already is much lower. So there are special things. The hallmark of acute hepatitis C and HIV is a much higher viral load. And that explains why some people were struggling to respond. Remember that the failures we've seen in the acute hepatitis C trials mostly derive from people with very high viral load, but that is mostly related to people who have HIV and who come with a higher viral load. And if you look at the longer treatment durations or the standard, and I guess that's one of the reasons why AASLD comes with a recommendation to use the same dosage as in chronic infection, then actually the overall failure rate goes towards zero. So I think it's then more sort of this attempt of physicians to think that potentially, because of the high cost of the drugs, we can treat shorter. Because remember, in the old days when we gave interferon, we got away with much shorter treatment durations and could spare a lot of the toxicity. And we always believe that there are different immune mechanisms and things would be much easier in acute hepatitis C, but that may not be true for shortening DAAs even further. And I think if we stick with the standard recommended dosages, then I think we should be fine. And the risk is really, really less than 1%, quite frankly.
Susanna, do you want to add to that?
Yeah, I was going to address, I see a comment in the chat on the 5% failure. I think this is again, I would really emphasize too, and I kind of put this in my summary slide that I blew right through, which is, I think in doing this, right, you want to make sure that we have learned through the trials for DAAs that there are novel variants, right, out there in terms of subgenotypes, et cetera, that have at times been, we've seen potentially more challenging to treat with pan-genotypic regimen. So I think this is a controlled situation, right, where we can ensure that the viral strains that we are involving in these studies are in fact ones that we are highly confident and well experienced in treating and curing versus ones that we have discovered throughout the global trials.
So when we come to, I mean, we've been sort of talking about the DAAs fairly generically as treatment for this, and you did show us data from both the common pan-genotypic regimens. Maybe I'll ask Norah, do you think there's a difference? Do you think there's a preference for one DAA regimen over another? Does it matter which genotype we're treating? Any thoughts?
I honestly think that for a treatment-naive patient that, you know, the main differentiating which one you choose is based on drug interactions. Quite honestly, that's usually the thing that drives you to choose one over another. And I think in a CHIM study, you're going to be thoughtful about ensuring that people are not on medications that would be a contraindication, for example, to using one of these regimens. For example, we all know that some anticonvulsants are actually very challenging to use with either of our DAA options. So, you know, just being thoughtful about those kinds of things, I think would mean that we'd be fine in terms of, you know, selecting one or the other. I think the key thing is having access, as has been highlighted. So I personally think they both are strong candidates as the first line treatment, and I wouldn't choose one over the other except based on DAAs. And that's true for genotype 3, which you might be getting at a little bit, but I think actually as initial therapy, I still am perfectly fine in terms of thinking about using either of these as first line treatment.
Yeah, and I certainly don't want to push on that point. I agree with you entirely. And Susanna mentioned about genotype in her comments. So I guess would we think differently about the different genotypes? It sounds like most of us, I think, would be comfortable saying it doesn't matter with, remember, this is a person this is an acute infection and someone without liver disease and a first round treatment. What about, I guess I'll just throw it out there, but any concerns about using a protease inhibitor containing regimen in someone with more severe acute infection? I see some head shaking, but Graham, I'll put you on the spot. What do you think?
Thanks. No, I don't. I wouldn't be too concerned about a protease. I would just push back a little bit on the genotype 3 question. I think most of the genotype 3 we see is 3A, which is probably non-problematic. The 3B has got associated issues with it. Some of the genotype 4s have got concerns about sofosbuvir usage. I think one of the slightly broader questions here is, what is our target audience? And are we looking for a pan-genotypic vaccine? And I think Michael raised in the earlier session this rather important point of feed through. Are we looking to develop a vaccine for US? Are we thinking about a Pakistan type vaccine or a genotype 6 vaccine for Vietnam? Or do we need a pan-genotypic? And I think that needs a little bit of thought when we consider the strains that we're going to use. I think if we're going to Pakistan, where 3B is 15% of the population with a slightly lower sensitivity to sofosbuvir, you might want to reconsider your approach to using a blind, any drug combo will do. So I think there does need just to be a little bit of thought as to our target audience when we think about genotypes and therapy.
Jake?
Yeah, I mean, just getting back to the genotype, I think for the CHIM study, it's somewhat of a moot academic point genotype, because we'll be selecting a particular inoculum that has been shown to be responsive to DAA, right? That's one of the, obviously, the criteria we will use. So it's probably not as relevant, but certainly we would need to be very careful in choosing the correct inoculum, which will be discussed further in the next panel as well.
Yeah, it's a great point. Ray Chung's going to talk about the selection of the inoculum, and when I talk about the clinical trial design, I will highlight that point that any inoculum we use will be an inoculum that has been shown to be sensitive to the DAAs we are going to use in the trial. And really what I was asking a bit more generally was whether there would be any preference for one regimen broadly over another, which it sounds like probably not. That would be more related to the safety of the drugs in the context of potentially a more severe acute hepatitis. But it sounds like most people are pretty comfortable with a protease inhibitor in that setting, and I would tend to agree. Norah, I see your hand.
Well, I was going to just disagree a little bit about the protease inhibitor. If the bilirubin is elevated, I would move away from a PI inclusive regimen. So I think if the bilirubin, is over 3, you have somebody who's really manifesting the more severe end of the spectrum where the bilirubin is rising, and now they're moving to being, say, somebody who's got a Child-Pugh score that's now 7 because their bilirubin is elevated or their INR is up. I would not use a PI inclusive regimen there. I would move towards a PI, one without a PI, just in terms of the information we have around safety. It's not a huge point, but I think we have choices, and I would move towards one that did not include a protease inhibitor if they're manifesting that kind of severity.
Great, thanks. And that was sort of the point that I was trying to raise with the acute hepatitis. And I think there really are not a lot of data in this setting, because as Susanna pointed out, very severe acute hepatitis C is fortunately rare. But it is also reassuring that in the setting of even fibrosing cholestatic hepatitis, in the setting of liver or other organ transplants, that therapy is effective even with that very severe form of acute hepatitis C, and people have tended to use sofosbuvir NS5A based regimens in that setting. To be honest, I'm not aware of whether protease inhibitors have been used in that setting, but that's a reasonable consideration. So moving back to this complications question, because this is the one that really, I think, is the thing that keeps all of us up a little bit at night. Are we going to be, I think most of us are pretty comfortable we can cure the people if they don't clear on their own. But I think we are worried, is there something we're doing long term? And I think one of the questions that comes back to this question of duration is whether we think the duration of the acute infection, 1 month, 3 months, 6 months, does that affect the likelihood of developing any of these chronic sequelae if they are to develop? Maybe, Graham, since you brought up the question about post-fatigue, I'll turn it to you to start, but I'd be interested to hear what others think as well.
I suspect that it will be duration of infection related. And I say that without any good data, but it just seems to me intuitively, if you have a brief infection of 3-4 weeks that's aborted, rather than if you started to get your immune response, your interferon response engaged for a prolonged period of time. So my suspicion would be that it will be duration related. I've no evidence to support that, but it just feels more sensible to be conservative. So I would be more comfortable aborting these infections at the earliest stage. I think what we're looking at surely is a sterilizing immunity. So you give people a slug of virus, they don't get any viremia at all. So that question can be answered, I think, with a fairly brief exposure. And my view would be that's more likely to reduce the risk of off-target effects.
We'll come to that discussion of sterilizing versus non-sterilizing immunity, because and there's definitely some differing opinions on that. We will discuss that, I think, at some length later in the session. So I'm going to I'm less optimistic that we're going to achieve sterilizing immunity, but I'll turn it to Norah to weigh in on this question of duration.
Well, I'm going to sort of take a slightly, I think this idea that there may be epigenetic changes that occur in the liver related to kind of more prolonged infection is something that we should be a little bit thoughtful about. And I appreciate the data looking in particular at HCC, which probably is kind of the major concern I think that most of us would have, if whether there's any, if it confers any increased risk. The thing I'm a little bit just aware of is that the patients that we're going to propose to infect in 2023 or 2024 are very different from the cohorts 2 decades ago, which is the data you're looking at. The presence of especially masked in the population. The fact that you're going to have individuals that probably have some degree of liver, they may have liver injury even related to fat in the liver. We just have to be aware of that. And is that an environment in which when you have Hep C infection that the outcomes are going to be in some way modified or changed? So just thinking about the patients that we currently have, like, you know, the frequency, especially of metabolic dysfunction associated liver disease these days is important, I think. So I would just, you know, I think that that's my concern. And so longer for me, I also would be, like Graham, more enthusiastic about a shorter exposure with this, with no data, but really this idea that, you know, longer viremia, longer the sort of ability to have kind of this, you know, having immune response within the liver, epigenetic changes. I'd just be concerned about long-term consequences. We just should be thoughtful about that piece, I think.
Absolutely. And I'm going to talk a little bit about that in my discussion about clinical trial design and the rationale of earlier versus later treatment. So we'll save some of that discussion for later, but Jurgen. Jurgen.
Yeah, I just want to follow up one thought on the fatigue issue. I mean, if you think of COVID, because we now have so much research going into long COVID syndromes, there the appearance of the syndrome is very much correlated with presence of viremia. And if viremia goes down early, then it's less likely. So I think there's, at least from other viral infections, some evidence which supports that duration of viremia may matter. And if you believe in these concepts of, you know, first or second hit of liver damage, I think if there's pre-existence changes in the liver, that may have an impact on also on duration of infection if there's already something pre-existing which may worsen then. Eventually, I would though argue that in the setting of a new concept which is being developed, you're going to choose patients who are liver healthy. So I think that risk can probably be eliminated, at least largely, by inclusion of your first volunteers.
Great, thanks, Jurgen. Dave?
Yeah, just I wanted to make clear that I agree that epigenetic changes are important, but I believe they probably occur with every infection that you get. And the available data suggests they occur fairly quickly. And I didn't get into these details. I actually hid the slide so I could get done in time. But the ones that were in the gastro paper, as we discussed in the chat, were principally 60-some% of it was explaining fibrosis, was an indicator of F3, F4 fibrosis, not an indicator of Hep C infection. So I think I'm worried about that, and I'm worried about it for like the post-infectious fatigue. I'm worried about it for other reasons as well. I don't think it's unique to this CHIM. I think all CHIMs should have to, all CHIMs have that issue. And anytime you give someone an infection, it's a real concern. I think when you think about the time scale, it's worth thinking about it is 6 months. 6 months is double 3 months, but 6 months compared to 3 months compared to 30 years, you know, and so I think it depends. Most antibody specificities have expressed themselves by 3 months and 6 months. So I don't know. I really don't know. And I wonder if it's more subjective. And I would come back to your later point. I know you're going to make this, so I love it. If I would rather have 6 if it makes a study valid. Because if we theoretically feel like maybe there's some increased risk, but we invalidate the whole study by cutting it at 3, then that doesn't do anyone any good. So those are my thoughts.
Yeah, and I guess just to add a little comment to the epigenetic changes, because I will tell you, we spent a lot of time poring over those data. And I think one thing that's really interesting is that you really do see in the in vitro models, you see the epigenetic changes 100% of the time. And in people with chronic Hep C infection, when you biopsy them, you see the epigenetic changes 100% of the time. What you see is that the people who developed cancer in those cohorts were exclusively people with cirrhosis. So my take on it is that this is a phenomenon that happens with Hep C infection, but that you don't develop liver cancer unless you develop advanced liver disease. And at least in this setting, and there are no data on whether these epigenetic changes occur with acute infection or acute resolving infection, and whether they disappear over time, to know the real answer to that question. But I think it's important to really highlight the fact that cancer almost never occurs in the absence of fibrosis, and most commonly occurs only in people with cirrhosis, even if it's after cure. So I guess this brings up another question, which is how long do we have to follow people after a CHIM? So we're talking about these long-term consequences. Some of them might happen decades after we expose people. So Christine, what's a reasonable time frame to be thinking about asking someone to keep coming back for annual evaluation?
I mean, based on sort of, the meta-analysis we did and kind of looking at these cohorts, it seems like the, HCC risk is, minimal, if not negligible, and very low. And, the rates are not at rates where there's an indication for HCC screening. So, I mean, I guess if you want to be cautious, I would like to follow them as long as possible, because I think risk is not defined by one time point. Risk is a trajectory, right? And so, we take these healthy volunteers, and if all of a sudden, one healthy volunteer is drinking heavily or has gained a lot of weight or developed diabetes, that may change their risk of HCC. And so, I certainly, I don't have a good answer, but I guess I would follow annually until somebody tells me I have to stop following them. So I mean, for me, I feel like risk is not necessarily defined by baseline demographics. So.
I think that's a great point. And I think all of us feel that we certainly need to follow people long term. And I guess the question is, what is long term? Is 10 years? It seems like a long time for people, but when we're talking about some of these very late complications, we really might be thinking about 20 or 30 years, and whether that's practical to ask somebody to commit to that. I think that's a lot to ask of them. But on the flip side, there is potential benefit for them of early diagnosis or identification if problems were to occur. So there may be some benefits of that. And I see a comment in the chat that I think people feel like probably 10 years is probably the minimum, but whether we need to go longer is a question. So I think I think our time is about up. I'm looking to Jake to see if there's anything.
Well, I mean, certainly we can take an earlier break if people have enough discussion. So I'll leave it up to the panel and people in the audience. I think there are a couple questions in the Q&A. You may want to just look at
yeah, and I think some of these questions probably relate a little bit to some of the other topics, but we have a great panel here, so maybe I'll ask them what they think about them. And I think this is an interesting risk question, because we don't necessarily think of it as a risk in terms of the disease, but what about any risk of stigmatizing or insurance discrimination for someone who tests Hep C antibody positive after participation in a CHIM? Susanna, what do you think?
Yeah, you actually saw that question, and I hope there's someone here who knows whether or not a HCV positive antibody is considered a pre-existing condition in the United States. My general understanding is that it's not, but someone may know better than I do, frankly.
Ellie, I see you. Okay.
Yeah, I mean, I do have a bit of experience of this through Hep C vaccines that we gave to patients, and they seroconverted and developed. Sorry, we gave them to healthy people, and they seroconverted, and they developed Hep C antibodies as a result of vaccination. And there are long-term consequences of that. For example, you can't be a blood donor in the UK if you're Hep C antibody positive. So. And the same thing would occur for these healthy people in a CHIM study. They would be excluded from future altruistic kind of endeavors, I think. So I think that does have to be considered, and it would be part of the informed consent.
And I see that Mark Solkowski's added in the chat here that people, at least in some settings, there may be screening for Hep C antibody by insurance companies. If they test positive, then it's beholden on the person to prove that they're negative, which is just an added barrier. So, I mean, it's certainly something that needs to be in a consent form. And I guess a question beyond that is whether it poses any other risk. Andrea, I see you're here.
Yeah, I suspect Ellie did this too, but we actually provided a card to vaccine participants saying that they had potentially falsely positive HCV antibody tests as a result of participating in the trial, and provided a way to contact us for questions. Complicating our trial, which wasn't people actively injecting drugs, you know, they could actually have hepatitis C virus infection. So we also educated participants and encourage them to have their providers call us, because HCV RNA would be the appropriate way to screen them for infection. We did not want people to not get tested for hepatitis C after leaving the trial, but in people at no risk for hep C, that card is probably particularly important.
And it's a little bit different, obviously, in this setting, because it's not a false positive, it's a true positive. They were actively infected, and obviously the blood donation issue is really a little bit of a question about whether there's any long-term risk of transmission in someone who's PCR and NAT negative, which is why people have been excluded to date. Whether that will ever change is a question maybe for Harvey Alter, but in the current setting, it probably will continue to be an exclusion. So it is something to warn people. And for sure, this point about that they need to know that whether they've been vaccinated, not vaccinated, or otherwise, that they could still be reinfected. So they shouldn't assume that anybody positive is of no concern. Andrea, another comment?
No, I left my hand up, but I will say that I agree. And in talking to insurance providers, they have said that they assess risk differently, because people who are antibody positive, it's a marker for higher risk behavior. I think that's very prejudicial, but that would not be true of someone participating in a vaccine trial. And that's my experience with insurance providers who've said, well, we view that as a marker of risk behavior that may change, for example, life insurance prospects. That I'm not sure it's fair, but it is something that has been brought up when I've challenged insurance providers about risk in someone who was treated.
Yeah, and I think that sort of gets to the point about stigma is real, and we shouldn't underestimate that, and people need to be advised of that if they are going to participate in something like this, that they may receive some stigma related to that, and hopefully that is changing and will continue to change, but it has not disappeared yet. Jake?
Yeah, I was just going to follow up on that question. And unfortunately, we don't have a sort of insurance policy experts on the panel. I think in general, pre-existing condition cannot be considered in a lot of these insurance, especially national health insurance or other things that you associate with your company or Medicare. And so I think this is really more and more interest in not to consider these kind of pre-existing conditions. Actually, in some states, it may be illegal to do that, to exclude somebody because of pre-existing conditions. So I think that thing is going to change, but I certainly agree that provide some kind of oversight in terms of this person was involved in a vaccine trial, therefore they have antibody, is very reasonable and easy to do. So I think we just have to see how that play out. So.
Okay, and I'm going to give Harvey Alter the last word on the on this.
Nothing insightful, but I didn't consider that possibility because they would exclude people from blood donation right now. That would require FDA changing the rules on donation. A lot of people are very devoted to blood donation, so for some people it would be a real negative. I don't think it's a big point, but especially with the small numbers you're going to enroll. But it is another consideration.
And I think it's important in the population that are going to volunteer to participate in a CHIM. On balance, this is a group that are probably more likely to be blood donors. They're more likely to be health activity. So I think it is certainly something that needs to be in a consent form, and people need to understand that. And whether there ever will be a change in the policy around blood donation is obviously questionable, but probably not likely in the short term. So I think that's certainly a relevant point to have raised. So I think we've covered a lot of ground in this panel with some great talks and some good discussion. And I think it's good to be sort of mindful of some of the uncertainty around the long-term risks, but confident that the risks are low, albeit they may not be zero, and thinking about how we inform people about those risks and then how we follow them to ensure that we keep their safety top of mind will be things we have to think about carefully. So with that, I'm going to turn it over to Jake. Thank the panel members for all the great points and discussion, and move on with the session.